Good morning, thank you.
Good morning. Chair, the first witness this morning is Dr. Rachel Bingham.
Thank you, Mr.
I do solemnly, sincerely and truly declare and affirm that the evidence I shall give
shall be the truth,
the whole truth,
and nothing but the truth.
Thank you.
Thank you. Can you give your full name, please?
I'm Dr. Rachel Bingham.
And what are your qualifications?
I'm a GP. I obtained my qualification as a doctor in 2009 from King's College London School of Medicine, from where I also had a master's in philosophy of mental disorder. I went on to complete my training as a GP at University College Hospital London, getting my MRC GP, or Member of the Royal College of General Practitioners, in 2015. Alongside my training as a GP, I've developed my interest in the medical care of asylum seekers and refugees through training at Freedom from Torture and Medical Justice in assessment of survivors of torture and ill treatment using the Istanbul Protocol. And I've supported that with diplomas in medical care of conflict and catastrophe, forensic medical science, and in public health.
Thank you. Your role is the clinical advisor to medical justice, is that right? What does that role entail?
That's right. So as clinical advisor, I provide clinical technical support to our team of caseworkers, for example, answering medical queries or looking at medical records in our cases. I do casework myself, seeing clients and writing medical legal reports, doing medical assessments. And I provide support and training to our network of about 65 volunteer doctors.
And in a nutshell, what does medical justice do as an organisation?
Medical justice provides support and help to people who are have medical problems in immigration detention or have medical needs, including a need for medical evidence in their asylum case. And as an organisation, medical justice provides clinical evidence and casework and policy work relating to immigration detention.
Medical justice has a number of volunteer doctors. You say in your statement they're mostly GPs, but do they also comprise other disciplines as well?
Yeah, that's right. They're mostly GPs, but we have doctors from a range of specialties, from surgical, medical specialties, and a number of mental health specialists, psychiatrists and psychologists.
You say that they have to have a certain amount of experience to be able to volunteer for medical justice. Just explain that.
So for medical doctors, we require them to be 3 years post their foundation training. So that's 5 years post-qualification. For GPs, that normally means qualification as a GP or equivalent relevant clinical experience.
Medical justice provides training for the role of volunteer doctor. Just summarise what that training involves for me.
So we do a basic training, which is some home or remote learning to work through some modules in assessment of mental health in detention, assessment of scarring, and in self-care. And then we support that with a face-to-face one-day training, which goes back over those topics, introduces people to some of the legal aspects and policy aspects of immigration detention, and then focuses on medical aspects of assessment of people in detention. That's our basic training. And then having done that, we pair up new volunteer doctors with experienced doctors to observe assessments taking place. And they do that as much as they need to, depending on their prior experience and expertise, before perhaps doing a joint or observed assessment with an experienced doctor, again, until they feel confident and competent to be able to do that role themselves.
There's a particular process for the completion of medico-legal reports at Medical Justice. Again, just summarise what that is for me.
That's right. So the medical legal report is done in normally a face-to-face or since COVID, sometimes an online consultation between the doctor and the client. That's usually at least a 90-minute assessment. If there's a need for interpreting or a longer assessment, could be several hours of a one-to-one assessment of. If it's a general GP, it might be an assessment of their mental health and of any scarring. After that, the doctor writes a report which details their clinical findings, reviews the person's medical documents, looks at, for example, Immigration Detention Centre medical records in detail, and putting all that together forms their opinion, and the questions that they would likely cover would be about the consistency of the presentation with the person's account, so the extent to which the findings are evidence of torture or ill treatment that the person's reported in their asylum case. There might be other questions they would cover too, but often focus on that. Having produced their report in draft, that report goes to a caseworker and a clinical reviewer who is an experienced doctor for a clinical review, which is a peer review really, but by an experienced clinician. We have a small team, just 6 experienced doctors that read all of the reports at that stage, so that helps us to provide some quality assurance and ensure a consistent standard for our reports. And then after that, the report would be finalised with the doctor.
Thank you. For the purposes of giving evidence to the inquiry, you prepared a statement, and it's at BHM 000033, and I'm going to take you to some parts of that statement, and in particular to the case studies that you have analysed in preparing that statement. I'm not going to take you to absolutely everything in it, because I'll ask that the statement in its entirety is adduced into evidence. And what that means is that it stands as your evidence, so I don't need to ask you about every single line in it. In relation to the case studies you've looked at, you've been able to analyse those and identify various themes arising out of them. How many case studies did you look at?
Sorry,
Roughly.
I don't have the answer off the top of my head, but at least 90 Rule 35 reports plus the 6 detailed case studies I've appended to my statement.
Yes, thank you. I want to look at then various of the themes that came out of those case studies that you deal with in your witness statement. The first one you identify as a failure to recognise symptoms of mental health problems in IRCs. In particular, you refer to PTSD and depressive disorders. And at paragraph 61B of your statement, which is at pages 21 and 22, your statement should be in the bundle in front of you at tab 1 if you need to refer to it. You look at the case of D1525, and again, you should have a cipher list in front of you. We're referring to the detained persons by their D number,
Yes.
and not their name, for reasons that will be obvious to you. D1525 disclosed to a nurse that he had been kidnapped, beaten and had scars on his back and arm, and that he suffered flashbacks. And a Rule 35 assessment carried out subsequent to this disclosure documented his account of torture and trauma-related symptoms of flashbacks, anxiety and fear. And although the GP concluded that D1525 may be a victim of torture, he didn't make any comment on D1525's mental health, even though there were those apparent trauma-related symptoms present. He was seen by a mental health nurse who subsequently assessed him, but also didn't explore those symptoms further. And he was under the care of the mental health team for 2 months, but no one from healthcare undertook any specific investigation into his trauma symptoms. He was then referred to medical justice. He was diagnosed by one of your psychiatrists to have PTSD and to have been adversely affected by his detention. And following that report being produced by medical justice, he was granted bail. What sort of failures do you consider that this case illustrates?
Thank you. I think this case is a fairly typical example of the types of failures that we've been highlighting. So starting with the Rule 35 assessment, which, as you say, was an assessment to document his history of torture and any associated features. So in this case, the individual has said that he has flashbacks and fear in episodes, and the doctor has noted that these are not very often, and the person is saying they manage them themselves. And they've gone on to conclude he's been referred to the mental health team, and that the only mention of mental health issues in the concluding sections of the report, which is essentially the summary of the advice to the Home Office about the person's condition, it just says some low mood and referred to the mental health team. So the implication is this person can be managed in detention. But actually, looking at the bigger picture, we've got somebody who's given a history of torture and is now giving a clinically plausible account of flashbacks and episodes of fear, which are clearly features of PTSD, so they're clearly symptoms related to a history of torture. So that should be recognised and flagged up. Why is that particularly relevant here? Well, because a person who's given an account of torture is now in detention, which is an environment that is known to trigger and exacerbate exactly these types of symptoms. So these are the most relevant symptoms to identify in this context. And what does it mean to miss that? Well, it means leaving the person in a situation where those symptoms will be exacerbated. And that's really a source of extreme distress and suffering, because flashbacks being exacerbated, it's not just a symptom that happens in passing. That's a re-experiencing of torture. So what's happening in the person's experience there is going to be as if they're being tortured again. So it's really important from a clinical perspective that a risk of that symptom being exacerbated, which we know to be a risk in this environment, is picked up and flagged up, but was missed in this case. And as in many cases that we continue to see, this person then went on to stay in detention until one of the medical justice doctors picked up and diagnosed the PTSD, and we can see that did lead to the person being
his
released.
Yeah. Do you have a view as to the reasons for these types of failures occurring, particularly given that the Rule 35 forms themselves direct consideration of mental health symptoms, don't they?
Yeah, that's right. And one of the questions in the final section is to specifically consider if there's a risk of deterioration in that environment. And one of the other questions is to highlight psychological consequences of the ill treatment the person's described. So there is the direction there in the form, and yet we repeatedly see that is missed. The reasons, I think, for missing this safeguard, it's not therefore that there's a lack of clarity in the form that needs to be filled in, but it's that it's not done. So to answer that question, I think we need to look at a bigger picture of systemic failures to implement these safeguards and to fully understand their importance.
Would training help?
I think training is important, but as I say, the information is there. So we think that there are systemic failures in a bigger picture of why these things are not being implemented. I think, as has been described in elsewhere, the clinicians are working in an environment which is not conducive to recognition of these symptoms. First of all, there needs to be a disclosure, so the clinicians need to be perceived as independent and able to advocate for the patients. And then when there's a disclosure, that needs to be recognised and acted on by the clinicians. But actually, we think that there are many systemic and environmental factors that mean that those steps don't happen.
I want to look at the case of D1527 next, please, and your statement comments that this case illustrates a number of different concerns or failures in the system. We are relatively familiar with the case of D1527 now, given the evidence to the inquiry. His medical records contained multiple indications that he was at risk of suicide. On arrival at Brook House, he was already on an ACDT. He had a past history of suicide attempts, and you say that that's a strong predictor of future risk. Is that right?
Absolutely, yes.
He also had a past history of self-harm and ongoing self-harm, which you say also increases the risk of suicide. So not just previous suicide attempts, but other acts of self-harm are also an indication of a high risk of suicide.
Absolutely, yes.
He expressed hopelessness and possible auditory hallucinations. In addition, he was recorded to state suicidal intent, so he was making a disclosure that he intended to commit suicide. None of this information appeared to have been drawn together by anyone, you comment, in healthcare, to recognise and communicate that he was someone at high risk of harm and deterioration in detention. The relevant mechanism for managing risk of self-harm and suicide appears to be the ACDT. Would you agree with that?
I think ACDT is what's used to manage these risks, yes.
What is the problem with the ACDT system in management of self-harm and risk of suicide?
So ACDT is not a clinical tool. So it's not a therapeutic or a clinical response. It's more of a management response for behaviours that are problematic and difficult to manage in a secure environment. So it doesn't address at all the underlying causes. It doesn't provide any sort of treatment or therapeutic intervention to alleviate the person's distress or to improve the symptoms of their mental health.
So is it an adequate response to the risks presented by someone who's presenting with self-harm or suicidal intent?
No, I think for those reasons it's an entirely inadequate response. I would also refer to Dr. Brodie Patterson's statement, who's explained that ACDT is a prison-style response not at all suited to clinical presentations in immigration detention, because it doesn't address the underlying psychological symptoms, because it doesn't relieve distress, and because it doesn't provide any therapeutic input. It's not only an inadequate response to those things, it's just not a response to them.
It also doesn't appear to either automatically or through any particular process trigger the consideration of Rule 35, does it?
No, there's no automatic triggering of Rule 35, and I think that's very clear from the lack of Rule 35 1 and 2 reports.
Is that also a significant concern in relation to the management of those with self-harm and suicidal intent?
Absolutely. I mean, the absence of Rule 35-2 reports means that suicide intent was never communicated to the detaining authority in a way that triggered a review of the suitability of that person for detention. So that safeguard is entirely absent.
And that's a significant concern, clearly. It seems still currently to be the case, is that right? Is that your experience?
That's absolutely right. I haven't seen any Rule 35-2 reports since the period of the inquiry.
You also say in relation to D1527's case at paragraph 160 of your statement that it demonstrates the use of segregation as an indirect and inappropriate means of managing his distress, symptoms of mental health problems and self-harm. Is that right?
Yeah, that's absolutely right. Segregation is an example of what the security staff have recourse to in the absence of mental health training and in the absence of an understanding of an appropriate clinical, they're not clinical staff, and in the absence of an appropriate clinical response to people at risk of self-harm who are distressed or who are difficult to manage, people are moved to segregation. So that's very concerning for us. That's particularly concerning because segregation and isolation are factors that actually exacerbate mental health problems, cause deterioration in many mental health conditions, and are associated with increased thoughts of self-harm and thoughts of suicide, related to the environment and segregation and related to social isolation. And so what looks like a response to manage the behaviour actually exacerbates the behaviour and the symptoms, and therefore that can lead to a cycle in which the person's distress becomes worse and the response becomes stronger, whereas actually what is needed is a de-escalation and a therapeutic intervention.
In your view, healthcare staff should have been raising contraindications, reasons not to use segregation in D1527's case, is that right? Who should have been raising those particular concerns?
So the person in D152 was seen by mental health nurses, by nurses and by the GPs, and all of them had the ability to raise concerns. Only the GP was able to do a Rule 35-1 report to report the person as at risk and as deteriorating in detention. So it was important for the other professionals to raise their concerns to the GP and for the GP to then escalate those concerns and communicate as a safeguarding mechanism to prevent further harm.
So in your view, a Rule 35-1 report should have been completed in his case?
Yes.
And indeed a Rule 35-2? You also say that D1527's case illustrates the use of force and restraint on vulnerable detainees and used as a potentially harmful and inappropriate tool to manage mental health problems and expressions of distress. And at paragraph 142 of your statement, you discuss the incident on the 25th of April with Jan Pashali that we're all very familiar with. You say particularly that the entry in the medical records omits all reference to the assault or injuries which should have been documented by the medical team. Why is it important to accurately record a use of force in the medical records, in your view?
Well, it was a duty of any healthcare professional. It's very clear in the Nursing and Midwifery Council guidelines, as in the General Medical Council guidelines, that as professionals we have to document what has happened, what we have done and what our patients have told us. And this was clearly, however else it's looked at, a very significant event in which the nurse was party to. So she absolutely had to write down a record for posterity of what had happened and her involvement and the impact that she'd observed on her patient. In this case, clearly there was a serious safeguarding concern to be reported, so that would just add to it. But in any event, it should have been documented.
He didn't appear to receive an examination of his mental state after the incident. Is that right?
No, that's absolutely right, and I think that perhaps follows from the failure to document and communicate it within the team, that the implications of it not being in the notes is that people later wouldn't know about it and therefore care couldn't be provided.
Have you looked at the note that was recorded in the medical records by Nurse Joanne Buss?
Yes, but I think you'll have to remind me. Yeah.
I can certainly do that. It's at CJS 001002, please, at page 38. And just scroll down slightly, please. There's the entry on the 25th of April at 18:51 by staff nurse Joanne Buss, placed on a Rule 40 constant supervision as he refused to return to E-Wing, called to E-Wing at approx 1900, constant watch, had placed a ligature around his neck, removed by staff. Staff trying to engage with him, RMN Dahlia tried to engage with him with minimal effect, put mobile phone battery in his mouth, which he later removed, battery removed from his room, went to toilet and attempted to self-strangulate, angry and not engaging with staff, hands removed from his neck by staff, salivating ++, unable to take any observations, visual obs, rest 16, respiratory rate 16,
Yeah.
Is that right? Slight redness noted on his neck, 2000, got up and walked around the room, taken a small drink, restless, constant watch continues, not engaging with staff, plan, please review later this evening. Does that adequately record what we've all now seen several times in the footage?
Well, what we've seen in the footage is clearly very dangerous act by a member of security staff putting his hands on the person's throat, and so I don't think that is recorded at all, or any intervention or response to it. So I don't think this reflects what I've seen in the footage at all.
Even leaving aside the particular, as it's been called, chokehold applied by Jan Pashali, had placed a ligature around his neck, removed by staff, adequately record the use of force upon D1527, even leaving aside the chokehold?
No, I don't think so. No, I think there's much more exploration and explanation of what happened. I can appreciate the nursing notes would be brief, but this is a very serious incident that you would expect somebody to record in detail.
Does angry and not engaging with staff really cover accurately the presentation D1527 had in really quite severe mental health episode and distress?
I think this is an example of the sort of way that mental health symptoms can be reinterpreted as behavioural symptoms. We know that this is a person with post-traumatic stress disorder who would likely be very frightened in this type of threatening situation that he would inevitably perceive as threatening. And so this use of this type of terminology, angry and not engaging, it really misses the more clinical observations that I would expect clinical staff to be able to make about levels of anxiety and distress and mental health symptoms.
Yes.
So I think angry and not engaging, it doesn't really capture the clinical presentation.
It's not accurate.
No.
I'd like to move on then, please, to D13. You say in relation to this case that in relation to food and fluid refusal, a fundamental part of the problem is that the underlying causes of food and fluid refusal are not routinely explored. Is that your experience in relation to detainees who are refusing food and fluids?
Yes, absolutely. Quite often the only documentation is just refusing food or refusing fluids, but the reasons why are many. So we often see people who are in detention who have lost their appetite because of their mental health symptoms, or we see people who have paranoid beliefs about the detention environment, refusing food for that reason. It's correct that sometimes people are also protesting their treatment, and the one thing they have recourse to is to refuse food. But I don't think we can assume, especially as clinicians, it's really important not to assume that the reason is a protest or a disruptive behaviour.
Did that seem to be the assumption?
Yeah. Absolutely.
That seemed to be the assumption, that it was simply a protest, a conscious choice.
Yes.
And not as a result of underlying mental ill health or distress at being in detention.
No, exactly. I think that type of assumption we see often and we continue to see.
Food and fluid refusal didn't seem routinely to lead to consideration of Rule 35.1 or indeed Rule 35.2 reports. Was that your experience?
Yes, and that clearly follows from a failure to look for and understand the root causes of the food or fluid refusal.
And in your view, had it been appropriately considered, should there have been likely more Rule 35.1 and indeed Rule 35.2 reports in relation to some detainees who were refusing food and fluids?
Yes, that's right, because, for example, in the cases I mentioned where somebody has lost their appetite through their mental health, or where somebody has developed paranoid beliefs, often that is a consequence of a mental health deterioration in the detained environment, and clearly that fits into Rule 35.1, particularly now if the person's not eating or drinking, their physical health is at risk as well. So that would be really important to communicate.
You've also said that it's necessary to consider an assessment of mental capacity when someone refuses food and fluids. Was that routinely happening in your experience?
No, I don't think that was routinely happening, no.
Should it have been?
Yes, so especially at the point where somebody's health or physical health is impacted by refusal of food or fluids, a mental capacity assessment is essential. It is part of Department of Health guidance for how to manage food and fluid, people who are refusing food or fluids, and so it's something I would expect healthcare staff to be aware of, but we see that very often does not happen.
You say often detainees were put on an ACDT who were refusing food and fluids. That was the case indeed with D1527. Was that an appropriate response or adequate management of perhaps what were underlying reasons for food and fluid refusal?
No. So as I've said about ACDT, that's not a clinical response. So that's just a behavioural management response from the security staff. So that doesn't necessarily involve healthcare, and it doesn't trigger any of the safeguards like Rule 35 that were so important in this case. It definitely doesn't trigger a mental capacity assessment. So it doesn't lead to any clinical protection of that person.
And you say that ACDT has become, or is indeed, disconnected from the adults at risk framework. Should the adult at risk framework come into play in relation to food and fluid refusal?
Yes, if the person's properly assessed and their mental and physical health are assessed, and then if they're found to be, as in the cases I've mentioned, refusing food or fluid as a result of mental health issues or as a result of deterioration in detention, then that absolutely should trigger the adults at risk policy.
So if we look at D13 then, it's at paragraph 79B, page 28 of your statement. This is someone who intermittently stopped eating for various short periods throughout his detention at Brook House. There was a delay in identifying several episodes of food refusal and triggering the food and fluid refusal monitoring process, with observations belatedly imposed only several days after D13 had stopped eating. Just dealing with those observations, they tended to just be physical observations. Was that your experience?
Yes, absolutely. So the person might get their blood pressure recorded if they agreed, but there's very rarely an exploration of their mental health.
D13 was open to the mental health team throughout and subject to an ACDT for an overlapping period on account of his suicidal ideation. But you say there was no substantive assessment of the motivation for his food refusal or the potential interplay with an exacerbating effect on his mental vulnerabilities and risk to himself. Should a Rule 35(1) report have been considered in his case?
Yes, absolutely. So that goes both ways. His mental health feeds into why he might be refusing food and fluid refusal, if it's prolonged or repeated, may also have a detrimental effect on his mental health. So it needed to be considered as a whole picture either way.
And indeed, there should have been consideration of a Rule 35(2) report given overlapping suicidal ideation.
Yes, and as he was required to be on ACDT for a long time, shows he was considered to present an active risk, but that safeguard was just not implemented.
Looking briefly then at the assessment of mental capacity, you look at the case of D1275, paragraphs 81 to 96 of your statement, and you say in relation to, paragraph 93, in relation to the assessment of mental capacity of detainees, the approach in D1275's case exposes the detriment to a vulnerable detainee caused by the absence of a structured process by which concerns about a detainee's mental capacity are raised, investigated by whom, or guidance on what action should be considered thereafter. There wasn't a structured process. Was there any process for identifying issues about mental capacity?
No, this is a really difficult case of a person who became very mentally unwell and lost mental capacity. But I think the failures in this case are illustrative of failures we're seeing in the bigger picture. In this case, perhaps he was identified as somebody about whom there should be concerns because he was repeatedly booked in to see mental health staff. So this is a person who actually missed 13 appointments with the mental health team. On 3 occasions, he was discharged from the mental health caseload, and the missed appointments, unfortunately, are summarised in the medical records as a number of hours used up or wasted, if you like, rather than identifying that loss of appointments as a concern in itself. Why did he keep being booked in for mental health appointments and not turning up? Should be an indicator that there's something going on requiring more assessment. And in this case, those concerns are actually flagged up by the security staff. So security staff have asked for appointments with healthcare. At one point, security staff have raised the question of whether he has capacity to attend those appointments.
Yes. But none of that was followed up.
But none of it was followed up. On one occasion, a nurse attended the wing but didn't manage to speak to him, and then nothing else happened afterwards. So there is enough, looking at the notes now, there is enough information to see that there are concerns, but because there was no attempt to engage him, there was no message sent to him, there was no further telephone call to him, there was no further trip to the wing to try to find him, but because he wasn't engaged, he wasn't properly assessed, and his mental capacity concerns were not identified. In this case, that leads, as in other cases, to just a documented deterioration in his mental health. We don't know what would have happened if his mental capacity had been identified earlier, but we know that he was in detention for over a year without that being identified. And sadly, after release, he was so unwell that quite soon after release, he was admitted under the Mental Health Act to psychiatric hospital under a section. So he was a person whose health was really harmed by that process.
He was assessed to have bipolar affective disorder or a psychotic illness, and that he lacked capacity.
Yes.
But only after he was released from detention, after a considerable period of time, as
Yes.
you say. And there was no Rule 35(1) or any type of Rule 35 report in his case.
No, exactly, and that's particularly important in this case, because if the detention centre staff couldn't assess him, they couldn't be assured of his safety, and they should have communicated his risk if he couldn't be managed. In detention, there's no choice about which healthcare team to see. In the community, there are a choice of practices, other people the person might see, advocacy or support structures the person would normally use, but he didn't have that choice. There was only the healthcare team there. So if they were not able to assess him, they should have communicated that they couldn't manage him to the Home Office. But actually, I think what this case highlights is a failure to follow through on that assessment.
He simply slipped through the net.
Yeah.
In relation to Rule 35, I just want to look at some aspects of the Rule 34 and Rule 35 process. You were here on Friday to hear the evidence of Dr. Uzarali and Dr. Chowdhury, I believe.
Most of it, yes.
Dr. Uzarali gave evidence of a practice in relation to Rule 35 reports not being written or indeed considered at the Rule 34 GP assessment that's required within 24 hours of arrival at an IRC. Do you remember that?
Yes.
But the practice being that a second assessment appointment was booked if something was flagged initially through screening or in that appointment, sometimes booked after indeed a considerable delay. Do you have any comment upon that practice that appears to still be ongoing?
Yes, I think the practice is still ongoing. What we see in the initial GP appointment doesn't seem to fulfil a Rule 40 appointment. What we see tends to be an assessment of immediate health needs in detention, so usually limited to prescription of medication for long-term conditions. It's not a systematic assessment of the person's risks in detention, so it doesn't include a detailed assessment of their mental health, of their physical health, other than those perhaps medication needs that have been flagged up. And it doesn't identify people that might, for example, be survivors of torture. So it doesn't feed in, or it can't feed in to the Rule 35 process automatically because there isn't enough detailed assessment. And then we heard from the doctors that even where that those risks were flagged up, they weren't reported straight away because a further appointment was booked later down the line.
Yes, so leading to delays.
Absolutely.
So the safeguard under Rule 34, it isn't operating as a safeguard in identifying vulnerability at the outset of detention. Is that your view?
No, it's not, no.
In relation to D1525, you say here that that this is in relation to Rule 35. The doctor noted repeated and sustained beating by other villagers on account of his sexuality, which the police did nothing to stop. The doctor documented various prominent scars and noted flashbacks and anxieties, but concluded that the incidents of ill treatment were more an issue of an adult at risk. And you say it's concerning that the risk to D1525 of being in detention was not further explored. In your view, was there an adequate understanding amongst healthcare staff, including GPs, concerning the definition of torture and the purpose of Rule 35.3 as a safeguard?
So to take those 2 points separately, in terms of the definition of torture, as my colleague Teresa Schleicher has explained in her witness statement, there was a reported history with the Home Office where the definition had been changed, and it's not clear in this period in 2017 how clear the doctors were about what the definition was. And in this case, the Rule 35 report includes the old definition, which includes that the torture was authorised by the state. So you can see that that's fed into the doctor's conclusion there, and to say more of an issue of adult at risk. But the doctor has missed the clinical point. Actually, his assessment doesn't have to be a legal assessment. He's not being asked to decide whether or not the person should be a survivor of torture. He's being asked to document the psychological and physical consequences and the impact of detention on that person. And so I think whether or not the person was a survivor of torture has perhaps distracted the doctor from documenting what he should have focused on, which was the risk of harm to that person in detention.
Yes. And being an adult at risk doesn't preclude a Rule 35.3 report. Indeed, it's the opposite, isn't it? It should prompt consideration of it.
Well, exactly. I mean, it's the adults at risk policy. So he needed to communicate why that person was an adult at risk, which he clearly thinks they are.
You refer at paragraph 103 of your statement to research and literature in the public domain that someone who has suffered a past history of torture would be at risk of harm in detention. Is that right?
Yes, that's right.
And you say that in the medical community who work in IRCs, it's well known that that's the case, that simply having a past history of torture or trauma involves a risk of harm in detention.
Yes, so I don't think it's possible to escape that information really, because it's the kind of unanimous professional consensus. If you look at research into mental health in immigration detention, for example, a meta-analysis looking at all the recent studies of mental health in immigration detention The von Werden study in 2018 reported that all the adult studies showed an association between immigration detention and detrimental impact on mental health. So it's not that there's kind of conflicting literature to find. I mean, as GPs, of course, this is a specialist field, and I understand, of course, not all of us work with asylum seeker, refugee populations, but
those who work in IRCs definitely do.
Exactly, and our duties as a doctor is to keep ourselves abreast of information and guidelines which are relevant to our work, not to other types of work as a GP. So in this sector, we're responsible to be aware of the latest professional guidelines, by which I would include the successive statements by the Royal College of Psychiatrists, because they relate to the mental health care of people with mental disorders in immigration detention, which clearly the healthcare team are responsible for. And now there's NICE guidance about PTSD, which was in existence from 2005, they should be aware of. And now there's guidance from Faculty of Forensic and Legal Medicine about care for survivors of torture in detention.
Dr. Uzerali didn't seem to be aware of any of that. Is that acceptable in your view?
No, I think it's unacceptable, and I find it surprising that being a senior, experienced GP leading others in that sector, that he wouldn't not only know about it, but be trying to disseminate that information to his colleagues and proactively look for it.
Yes. You heard his evidence about how he applied the likelihood of harm assessment in relation to victims of torture. Do you think he really had any understanding of the safeguards under the rules in relation to the type of assessment he was meant to be undertaking?
No, I think that there was a lack of understanding about the rules. So, and that fits really with our experience. So Rule 35.3 reports tend to be done, albeit with the problems that I've described in my witness statement with them. But we know from Dr. Uzerali's evidence and from the other evidence that Rule 35.1 was very rarely done and Rule 35.2 was never done. And so, you know, we've heard from them that they were just not participating in that safeguard, which is clearly a policy that applies to their work and clearly a very important part of safeguarding, because that's the only mechanism by which the detention of people identified as adults at risk will be reviewed by the Home Office.
Yes. In relation to a failure to address mental health aspects in Rule 35 reports, and indeed a failure to assess the impact of detention, you looked at the case of D2442 at paragraph 110 of your statement. This detainee gave an account of torture. Under the mental health section of the report, it was noted that he had been started on some medication due to low mood and thoughts of ending his life. He was also noted to be under the care of the mental health team. He had tried to hang himself 2 days before the Rule 35 assessment. Yet, despite that, and despite what were clear and obvious reported symptoms, indicators of risk, it appears the opinion of the doctor's colleague that medication was required. The doctor concluded there was no evidence of severe mental health issues and therefore didn't go on to consider the impact of detention. In your view, is the conclusion no evidence of severe mental health issues justified in this particular case?
No, so this is a typical example where a phrase like no evidence of severe mental health issues is put in a context where it's then to be interpreted by a non-medical reader and allows clearly for the interpretation that there was no risk of harm to that person in detention. In fact, this person has made a very recent suicide attempt, is under care of the mental health team and is on medication. So there definitely are
severe mental health issues.
But that's not communicated. And I think one of the reasons for that may be a use of severe mental health issues to refer to psychotic mental illness. And clinically, perhaps that's a category that's recognisable and it makes sense. But it doesn't mean, it doesn't relate to the severity. So somebody could have PTSD or depression but not have that category of mental health issues. So they're not psychotic, but they still have severe mental health issues and are at risk in detention. And I think that's the case in this case. But the communication is unclear and the risk is not communicated. And so that safeguard, again, fails.
Yes. again, Dr. Uzarali confirmed in his live evidence, as indeed did Dr. Chowdhury, that they are still not completing reports under Rule 35.2, and indeed, as Sandra Culver confirmed, and indeed very few under Rule 35.1. That still remains a significant concern, doesn't it?
Yeah, absolutely. I'm as concerned now as I would have been then, that these safeguards just don't operate despite an ongoing very high prevalence of these types of mental health issues in people in immigration detention.
And the concern in relation to Rule 35.3 reports is that frequently, as in D442's case, where there's a failure to consider the impact of detention on him, even though the form directs it, there is then a reliance by the Home Office upon that lack of consideration in maintaining detention in cases where potentially there shouldn't have been. Is that right?
Yes, absolutely. So the Rule 35.3 is we see repeatedly, the doctor is quoted and cited in decisions to maintain detention. It will say that the doctor has not identified any harm to your health in detention. So we know how important that is. We don't know, and I don't think there is any sort of further safety net where that decision is fed back to the doctor and the doctor should then see the person again. If they were at risk of harm in detention and they're still in detention, they should be specifically reviewed to see what's happened to them since.
And there seems to be no system at all for ongoing review.
There is no system for that.
And a significant number of Rule 35.3 reports from the period, but indeed likely ongoing, continue to fail to identify the impact of detention upon a detainee at the point when a Rule 35.3 report is done.
Yes, more. That's usually not considered. Yes.
In relation to the use of Part C forms, there was some evidence given by both Dr. Uzarali and Dr. Chowdhury on Friday that they used the Part C form to inform the Home Office of a deterioration in a detainee's health instead of, or potentially in addition to, Rule 35, which Dr. O referred to as a weighty document. In other words, that a Rule 35 report was a weighty document. Do you agree that it's a weighty document?
I know, I mean, as a GP, I can relate to being busy and not wanting to duplicate efforts, but I don't think in this case it's very difficult. They can have a technology to copy and paste their findings into the same report, and I'm sure if they understand the importance of this safeguard, that would be clear that's what needs to happen. I note the same people have not raised concerns that they didn't have time to safely do their work, and I think that's the pathway. If you don't have time to follow safeguarding procedure, then you surely need to have raised concerns that you don't have time to do your work.
I'm summarising, but the evidence that Dr. Uzarali gave for the reasons for using Part C instead of Rule 35 reports was that it was a more dynamic way of informing the Home Office of concerns. They would get a response quicker, and in his experience, the receipt of a Part C would lead the Home Office to review detention and indeed release detainees, even though there's no statutory requirement for the Home Office to have done so. Is that your experience of the use of Part C?
No, it's not, no, because we see cases where there are Part Cs in the notes and detention has not been reviewed and the person stays in detention. But we also see cases where there is no Part C and no concerns raised. But in any case, the important point is that what's actually a safeguard is something that requires a response. So this is the same in all of our safeguarding training for safeguarding adults and children. There needs to be a process which triggers a response and can then be reviewed. And Part C doesn't require a response. It doesn't require a review of detention by the Home Office. So it's not a safeguard. It might be a communication in the best case scenario that they are saying happens sometimes, but it doesn't trigger a review of detention, so it's not a safeguard.
And in relation to Part Cs, they're also more general than just a concern about a detainee's health or risk, aren't they? They can be about a number of other different things, so it's not focused upon vulnerability in the same way that Rule 35 is. No,
that's right. It's not part of the adults at risk policy as a safeguard to flag up those safeguarding vulnerabilities. So it's not a safeguard. That's right.
In relation to D801 then, he had 4 Part Cs completed in relation to him and sent to the Home Office. He had arrived in Brook House on the 1st of March 2017. His screening by a nurse indicated a diagnosis of PTSD and a history of torture. An ACD was opened due to an increased risk of self-harm, but no Rule 35(3) report was done at that time, and indeed no Rule 35 assessment appointment was booked for him. Is that right?
No, thank you, and thank you for summarising. I think that's a clear example of repeated Part Cs not triggering a review of detention.
And if we look at just the chronology of the Part Cs and what was happening when each one was raised, he didn't attend his routine Rule 34 assessment that was booked for him on the 1st of March. That was with the GP. That was the day he arrived. But he did see Dr. Belder, who was a psychiatrist, on the 2nd of March, who noted he is experiencing flashbacks, overwhelming anxiety and high emotional arousal, insomnia, nightmares and severely low startled reaction. He also noted that he was very distressed during the appointment. A Part C had been completed in relation to D801 on the 1st of March, but he was maintained in detention after that. The plan Dr. Belder had on the 2nd of March was to transfer him to hospital under Section 48 of the Mental Health Act. Does that indicate that Dr. Belder thought he was very unwell? He needed inpatient psychiatric treatment?
Yes, that's right.
At that stage, at the 2nd of March, with that assessment, there should have been a Rule 35(3) and indeed a Rule 35(1) report, shouldn't there?
Yes, absolutely. They clearly identified a person who couldn't be managed in detention, who required a different type of treatment, who was at risk of harm in detention because of the symptoms that you read there that are characteristic symptoms of trauma-related mental disorder.
He was also the subject of a Part C completed by Sandra Culver that I asked her about when she gave her evidence, and he was noted on that Part C to be an adult at risk at level either 2 or 3. At that stage, again, no Rule 35 report completed. Again, there should have been, shouldn't there?
Yes.
And he was maintained in detention after the Part C on the 13th of March. On the 19th of March, it's noted in the medical records that the previous day he had applied a ligature, so a serious episode of self-harm, potentially a suicide attempt. Would you agree?
Yes, absolutely, yes.
And again, a Part C was completed on the 19th of March to notify the Home Office of the ligature. Again, he was maintained in detention after that Part C was sent to the Home Office. Again, at that stage, a Rule 35(1) and or a Rule 35(2) report should have been completed, shouldn't it?
Well, absolutely. So the Rule 35(1) should have been done already and certainly could have been done again. Rule 35(2) because suicidal intent has been demonstrated by a very serious suicide attempt, unfortunately.
And he, again, remained in detention. A note on the 31st of March in his medical records and prompting the last Part C in relation to him, recorded by Dahlia Dowd, that he wasn't fit to be in Brook House, he was unfit for detention, he should be released on health grounds, that he needed specific trauma therapy which cannot be provided at Brook House, and there had been no change in his clinical presentation to previously. And this was in circumstances where his Section 48 transfer had been cancelled, but not that he had improved. Is that right?
No, that's right. In this case, my understanding is that the person had severe PTSD and that was the need for hospital treatment. And it's actually illustrative of the fact that PTSD is not best managed in a detained or secure environment. People with PTSD have to be managed in a situation in which they're able to feel safe and secure and stable and to engage with treatment with somebody that they can build a trusting relationship with. So a secure hospital is not the ideal situation for somebody with that condition. Certainly an immigration detention is not, and the ideal context is in the community, which eventually was established in this case.
And to finish it off, he did eventually, on the 3rd of April, some more than a month after he had been received into detention, have a Rule 35(1) report completed on him by Dr. Chowdhury, and he was, by the time of the Rule 35 response from the Home Office, released.
Yeah.
So eventually the safeguard kicked in, but far too late, in your view.
It's certainly far too late, because harms that could have been foreseen on the second day of his detention, that he was somebody who had very high risk of deterioration in the detained environment because he was identified as having PTSD, was kept in detention so that his symptoms could be exacerbated and suffering to the extent of causing a suicide attempt and so on, as you've explained.
And Rule 35.1 in particular, we've been talking about harm being caused in detention, but the rule actually only requires that it's likely to be harmed, the likely to be caused, doesn't it?
Yes, that's exactly right. And the fact that a Rule 35.1 was done in this case, when we know there are so few, shows the type of extreme case that might trigger it in the GP, where a psychiatrist has recommended transfer to hospital. But that really illustrates how people are left to deteriorate until such an intervention is required rather than flagged up, which doesn't fit with the idea of an adults at risk policy that should try to identify risk rather than actual harm, as in this case.
And it's required by the rule, isn't it, as well? The rule isn't being applied in the way that it's supposed to be.
No, exactly, yeah.
Far too high a threshold, as Sandra Calver accepted, as being applied in relation to Rule 35.1 reports, which perhaps is one of the reasons why we see so few of them.
Yes, exactly, because they're done when people have been allowed to deteriorate to such an extent instead of done to identify risk as per the policy.
In terms of the reasons for the lack of Rule 35.1 reports, part of the reason might be a lack of time and resources. Would you agree?
As I said, I just don't think that is an acceptable reason, because I don't think that's been flagged up as a reason. I think there's a failure to recognise the importance of these safeguards. There's a failure to recognise the risk people are facing in detention, and a failure to recognise the responsibilities of the healthcare team and specifically of the GPs to implement these safeguards.
Yes, and that remains the case currently,
it does,
as we
yeah.
know. Dr. Uzarali, in his live evidence on Friday, also placed reliance on the ability of the GPs and the mental health team to manage a detainee's health in detention as a reason not to do these reports. Do you have any comment upon that practice?
So what we generally see is the GP's role is quite limited to prescribing medication or referring to the mental health team. The mental health team management is... So there's mental health nurses in detention with access to psychiatrists, but their role is quite limited to assessment and some supportive interventions. They're not able to provide therapy, psychological therapy in detention, because, as I mentioned, in order to do that, you need the person to be in a safe environment in which they can engage with treatment. And this is really clearly explained in the Royal College of Psychiatrists' position statement, that the majority of mental disorders cannot be managed in detention, and that was a clear finding repeated in the Shaw Review in 2016, so known before the period of the inquiry. People couldn't get good care in detention for their mental health. So the GP management can't be seen as adequate. It's not equivalent to what would happen in the community.
I'd like to move on to another case study, please, D1914, and you look at this at paragraph 80C on page 30 of your statement. You comment that the Rule 34 process didn't seem to have identified adequately his physical health issues. We know that he suffered from a serious heart condition and had a complex clinical history. He was taken to A&E by ambulance whilst he was at Brook House on multiple occasions after he complained of chest pains and palpitations, and following a blood test result indicating a possible blood clot. Is that right?
Yes, that's all right.
Does that sound to you as someone who has a stable cardiac condition?
No, well, I reviewed his detention centre medical records, which included some letters from his cardiologist, and they show that he'd had a coronary artery bypass graft sometime before he was detained, and although an interval had passed of some months, he was waiting for a further procedure, which was a catheter procedure, so an intervention through a blood vessel to treat an abnormal heart rhythm. So when he says he was having palpitations, he had episodes of an abnormal heart rhythm for which he was waiting treatment. So we know that he's a person with serious cardiac disease because he's required a coronary artery bypass graft, and we know that his condition has not been stabilised because he's waiting for a further procedure. all of that information was available in the medical records, and it was known early on in his detention. So he could have been identified early on as somebody who had a cardiac condition which would have contraindicated specifically the use of restraint, which you might come to, and also
Yes.
meant he was unfit to fly.
He didn't receive a Rule 35-1 report until almost 4 months into his detention. In your view, should he have received one much earlier than that?
Yes, I mean, I think those medical vulnerabilities should have been flagged up very early on. He also had mental health issues and episodes of serious self-harm and suicide attempts in detention. So there were multiple indicators to flag up his risk in detention,
Yes.
which should have been done much earlier.
Let's come to the use of force then. We know that D1914 was subject to a planned use of force in relation to an order to effect his removal to E-Wing on the 27th of May 2017 in advance of his charter flight. He had a serious heart condition, as we've just discussed, and he also, as you said, had a history of serious self-harm. He'd been on 3 ACDTs. Dr. Uzarali, as we heard on Friday, had written a letter to the Home Office that he was fit to fly and fit for detention. Was it appropriate, in your view, for GPs to be writing letters to the Home Office in such terms?
No, I think there's multiple issues with that. The GP's role in use of force is very strictly limited to a protective role. So they have no part in authorising or planning the use of force. It's not a therapeutic intervention. In this case, it was to remove him from the country. So it had nothing to do with his clinical care, and therefore it has nothing to do with the doctors, except that in this context they have a very specific safeguarding duty before, during and after a use of force. And so their role, I don't think it's being too technical. Dr. Uzarali said the language amounted to the same thing, but actually the language is how we separate this role clearly in our documentation. So saying there's no medical contraindications is the limits of the doctor's involvement in a use of force.
And it's very different from saying that he's happy for reasonable force to be used.
Absolutely, because that's an endorsement, and that very clearly steps beyond the boundaries that doctor should have. This is clearly flagged up in guidance for doctors working in this area. So the BMA report for doctors working in immigration detention explains about dual loyalties and how doctors can get drawn into custodial systems. And as GPs in that environment, they need to be constantly on their guard for that and really watch their language, so that it's not, as in this case, used in another context to justify a use of force.
Yes, as it clearly appears to have here. Dr. Uzarali also gave evidence that in writing these letters in these sort of terms, he wouldn't always assess the patient in person in order to write such a letter. Was that appropriate in your view?
Well, I think in this case there was enough information on the background information and the letters from the cardiologist to say that he was not fit to fly and to raise concerns about his restraint. But clearly, for most people, they would need an assessment in person because it might not be that crystal clear as I think it was in this case. There's also an issue about consent. So we're in a situation where a doctor is now going to share information with the detaining authority without having had a discussion with his patient about what's going to be shared and why, and whether or not there was consent for that information to be shared. And of course, that information, as he is the patient's GP in this situation, he needed to have the patient's consent to share that information.
And he should have been raising both the physical condition and the self-harm as contraindications to the use of force prior to the planned use of force, in your view.
Yes, absolutely.
And you remain of that view, even though Dr. Uzarali disagreed with you in his live evidence, saying that his condition was stable and neither of those things was a reason not to use force in this case.
I do remain of that view. I could see that Dr. Uzarali didn't have the medical records in front of him, but I've reviewed them before and since hearing that evidence, and I remain of that view, yeah.
You say also in relation to D1914 at paragraph 145 that his case also appears to be an example of a misconception among staff that non-compliant behaviours are indicative of deliberate disobedience rather than a manifestation of underlying vulnerability such as self-harm or mental ill health or distress. Is that your view in relation to him?
Yeah, so in relation to this person, I think there's a very high risk that that is what was happening. There are snapshots, for example, in the nursing notes, that this particular patient, D1914, was noted by the nurse to be very anxious, hyperventilating, tearful. We've seen in the panorama footage, unfortunately, evidence of very severe self-harm and suicide attempts, so significant overdose, blood found in his room, very large cuts on his body. We've seen these manifestations of distress there and also in some snapshots in the medical entries. But the overall view is the treatment of him through custodial processes, through use of force, through ACDT. These are managing as behaviour. So they're management, how you would manage if you didn't think somebody was unwell. That there's no justification for managing somebody with mental health problems in a high degree of distress through these restrictive measures. So recourse to them shows that the environment hasn't allowed this person to be treated as a vulnerable person, to be treated as a patient.
And is that an attitude amongst the detention staff and the healthcare staff, including GPs?
Yeah, I think there's a very high risk that those things go together, because if the GPs don't communicate those concerns and don't implement those safeguards, then they're not feeding into an environment that would listen to people and treat them with compassion. They're instead participating in an environment that's hostile to those people.
Yes. In relation to use of force in a different context, you comment about the issue of force being used in response to self-harm incidents. And we've seen this in a number of cases. D1527s is one, also D687. And one you discuss in your statement at paragraph 147C, D812. In your experience, does it seem to have been a widespread practice to use force in response to incidents of self-harm?
Yes, absolutely. I would say there was very quick recourse to use of force rather than to a clinical intervention, and that's related to what I said, to an environment that doesn't perceive these things as symptomatic of mental health issues, but reacts to them as challenging behaviours. So I think it's all connected. You mentioned D812, for example, who was subject to a planned use of force because of his risk of self-harm. So in that case, it's absolutely clear that the perceived indication for the use of force was a mental health issue, which was self-harm. And then when he was found, unfortunately, was with a plastic bag over his head, so in the throes of a very serious suicide attempt. And still the use of force proceeded after that. So at a time when clearly what was needed was a compassionate mental health intervention.
Yes, indeed, a shield was placed on his chest while he remained lying on the bed, and he was then restrained prone on the ground, a dangerous position in itself.
Yes.
His arms were restrained and his head was secured, and he was escorted to E-wing under restraint and in handcuffs. He dropped his weight to the ground several times, resulting in him being restrained again prone on the floor on at least one occasion. That does seem, as you say, to be a use of force as a tool to manage and respond to an acute episode of self-harm, as opposed to merely to save life in the immediate moment. Would you agree?
That's absolutely. Let me be clear. Force was rightly used to remove the plastic bag from his head. That was the extent of it. After that, he was no longer. I don't think there's a suggestion he was posing a risk to anybody else. And after that had been done, he was no longer an immediate risk to himself. But clearly, he just made a very serious suicide attempt. We can only assume that he must have been distressed and frightened at that point, when he was then subjected to the further use of force.
And the role of healthcare staff present at that stage should have been to raise a concern about an ongoing use of force or a contraindication to do so.
Yes,
right?
Absolutely. So that the healthcare staff present should have said stop and tried to assess the situation, which means tried to assess his mental health, tried to engage him and to decide what was needed next. Now that the emergency has passed, they had time to do that.
think lastly, then, we've touched on the use of segregation in D1527's case. I just want to ask about D2951 and the use of segregation to actually provide clinical care. At paragraph 163, you say that there do seem to be instances of segregation being used in a direct attempt to provide clinical care and protection for highly vulnerable detainees, and D2951 is one of those. He suffered from significant mental health issues and was maintained on Rule 40 segregation in early June 2017, whilst awaiting transfer to a psychiatric unit. So, given he was awaiting transfer to a psychiatric unit, he clearly was significantly mentally unwell.
Yes.
He appears to have been accommodated in a medical single occupancy cell in E-Wing, subject to a 3-man unlock. An IMB visitors report notes that E-Wing officers were concerned that leaving him locked in a room was detrimental. Would you also be concerned?
Yes, absolutely. Leaving somebody alone in a room amounts to solitary confinement, and the impact of that on mental health is very clearly documented and known. So his mental health was at risk, not just through the prolonged increased isolation, but also due to the actual circumstances of being held in a single room.
The Home Office continued to extend the authorisation for Rule 40 at each review until his ongoing care was arranged. And during this period, there were also concerns raised by the detention staff that leaving him in a locked room was detrimental to his mental state. He was eventually transferred to a mental health unit under Section 48 on the 15th of June, but he appears to have come back to Brook House in early August 2017. The use of segregation in these type of circumstances, awaiting a transfer or awaiting treatment for psychiatric treatment, was an inappropriate use of segregation in your view?
Absolutely. I think that's particularly concerning because now we're talking about the most unwell people that are actually assessed as in need of admission to hospital.
It's clearly not a substitute for mental health treatment.
Well, it is not a mental health treatment at all. It's worse than nothing because it's actually something that will harm his mental health. So not only is it not therapeutic, but it's actually going to contribute to his deterioration.
If someone's so unwell so as to need to be segregated, does that suggest they shouldn't be in detention in the first place?
Yes, absolutely, because as I've said, that's a harmful environment which is going to exacerbate their mental health condition.
My last question before the break, I think, subject to any questions the chair has, is I'd like to just ask for your view on any links between any of these failures we've just discussed in some considerable detail and the incidents we see of mistreatment captured on Panorama.
Thank you, yeah. So I think it's impossible to really separate these issues. We're talking about failures of safeguards in Rule 35.1, Rule 35.2, Rule 35.3, Rule 40, which means that vulnerable people are not picked up as vulnerable and they're kept in an environment. So we're talking about a failure of safeguards to stop vulnerable people being in this environment. Then we're talking about an environment which has a known negative impact on mental health. So where behaviours like self-harm, like distress, like mental health problems are treated as challenging behaviour, so an inappropriate response, that leads to escalating mental health problems, increased risks of self-harm. It's a perfect storm, and in that situation we have people that are then unqualified to manage. Their only recourse is use of force, solitary confinement. They don't have the capacity to do a therapeutic intervention, and so the possible responses are going to be inappropriate. I don't think it's possible to separate that from the abuses that we see.
Thank you. Chair, I don't have any further questions for this witness. Do you have any questions?
I don't. Thank you very much for your evidence, Dr. Bingham. I know it's not necessarily an easy experience, but it's been very important to hear from you. Thank you very much for coming this morning.
Thank you.
Thank you.
Can I suggest 1:45?
Indeed. Thank you.
you. Thank you, Chair. The next witness is Teresa Schleicher.
Thank you.
I do solemnly,
I do solemnly,
sincerely and truly
declare and affirm
that the evidence I shall give
that the evidence I shall give
shall be the truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Thank you. Can you give your full name, please?
I've always worked as Teresa Schleicher. That's actually my maiden name, so my full name is Teresa Veronica Pennington Schleicher.
Thank you. You are the casework manager at Medical Justice and have held that role since July 2009, is that right?
That's correct.
And what does that role entail?
I'm responsible for the individual casework we do. So I do some casework myself, and I have 3 caseworkers working with me. And we are the main point of contact for our clients who are detained. We then allocate clinicians who will carry out medical legal assessments, and we coordinate any follow-up work that we do for those clients. That might include advocating for them to receive appropriate healthcare, referring them, for instance, to legal representatives, and making sure that they receive care in the community when they're released. I also feed into policy work that we do in the organisation. So I have regular meetings of our policy team, and I have attended a lot of stakeholder meetings with the Home Office and other relevant bodies.
What is the purpose of those stakeholder meetings?
With the Home Office, it is for us to give feedback on how Home Office policies are working on the ground, what we see in our work with detained people. And also, the Home Office will often ask for our input in consultations on new policies that are being brought in.
You say in your statement that your casework covers primarily 3 groups of people in detention: those who report torture, those who have a clinical problem and need an assessment of their treatment and support, and those who allege that they have been assaulted or subject to excessive force in detention or during an attempted removal. Is that right?
That's right, and of course there's overlap between those 3 groups.
Yes. How does Medical Justice receive referrals?
Just over half of referrals are self-referrals by detained people who ring up, and most of the time they've heard about us by word of mouth from other people in detention. And the rest comes from a mixture of sources. There's a lot of referrals from legal representatives, and then from visitors groups, from other NGOs who work within detention. That could be Hibiscus or any of the other NGOs, and sometimes from family or friends of detained people, from clinicians they've worked with in the community, or from a range of other social workers.
What happens upon receipt of a referral? What's the process?
We take their initial details, and then they get allocated to one of our caseworkers who will speak with them more, find out what the help is that they're looking for. We will ask them for all of the documents they have with them to have an understanding of what's happened on their case so far. We will request their healthcare records, and then we have regular casework meetings at the moment 3 times a week, where we discuss those cases and decide what we can do for those clients.
And are you able to accept all referrals that come to you, or is there a prioritisation?
Unfortunately not. So we accept about 1/3 of the referrals that come to us, and the rest we will try to signpost to other organisations where we can. But in terms of providing medical assessment and evidence for people in detention, of course, we're the only organisations to do that. So we prioritise on the basis of where we think our intervention is likely to make the biggest difference. And so people who have survived torture, it is known that they're very likely to deteriorate in detention, so they're a priority. People who are very unwell, either mentally or physically, while in detention, again, they're a priority.
And you say at paragraph 19 of your statement that Medical Justice maintains a bespoke database. How many cases are on that database, roughly?
Oh, that's difficult to say, but we receive about between 800 and 1,000 referrals a year, and we've had the database since, I think, 2009. So they're all on there, a lot of cases. Obviously, for those who we take on, there's much more information on there because we'll continue to update it while we work with the person. For those where we're not able to take on the case, there's only relatively brief details on there.
And what do you use the database for?
To record our ongoing casework. So anytime we have contact with that person, we'll record that. Any steps we plan to take, we will record. What they tell us about their health, we record, and we upload their documents, so their healthcare records and any immigration documents that we have.
And does it perform a function in your policy work as well? Does it feed into that?
It does, because it means we can then analyse themes that arise from the casework that we've done.
You talk in your statement about the policy context providing a backdrop for your casework, and that's that vulnerable people, adults at risk, should only be detained in exceptional circumstances. Is that right?
Exactly. I mean, that was accepted right from when the detention centre rules first came in. It was made very clear that it was accepted that those who had survived torture or had mental health issues or other issues that made it very likely that they would deteriorate should not be put in detention because of that likelihood, and so they should be screened out straight away, either before entering detention or right after entering detention.
And as you say, it's because that cohort of people may be particularly vulnerable to suffering harm in detention.
Exactly.
In your view, mere immigration factors such as entering the UK illegally, overstaying or refusing to leave voluntarily couldn't or shouldn't constitute exceptional circumstances. Is that right?
Absolutely. And of course that was accepted by the Home Office as well until 2017 when the Adults at Risk policy came in.
What is, in your view, is the Adults at Risk framework and the safeguards under Rules 34 and 35 designed to achieve?
So Rule 35 and Rule 34 have been there since 2001, and they were designed to identify vulnerable people at high risk of harm in detention, for them to be identified straight away on entering detention and to then be released, so that they wouldn't stay in detention and actually suffer harm. That process never really worked. And there was then a number of findings of severely mentally ill people who suffered Article 3 breaches while in detention. There were also a number of deaths that raised similar issues. And following that, Stephen Shaw was commissioned to review the process of detention for vulnerable people. And the Adults at Risk policy obviously came out of that. Shaw identified that those safeguards weren't working effectively. He did say that the premise of having these groups of people that were identified who were at particular risk of harm was a good one, and that should be preserved and built on, and he then suggested some additional safeguards. And that's what we expected the Adults at Risk policy would do, but when it came out, actually it didn't do that, and we were really concerned that instead it looked like it was going to undermine the safeguards.
And in relation to defects in the Rules 34 and 35 rules and system for safeguarding vulnerable detainees, as you say, initially at the outset of detention, but is there a role for those on an ongoing basis in detention?
Absolutely. I mean, I think it's really important that people are screened and identified before they even enter detention, and that doesn't work. There's no proper process for that. And then those who are missed by that process to be identified as early as possible in detention. But of course, some will be missed by that, and so that it's really important that there's ongoing monitoring. And that's why Rule 35 is an ongoing duty to report to people at risk of harm, so that they can then be rooted out of detention as quickly as possible.
What do you see as the main defects that remain in the system of Rule 34 currently?
So Rule 34, I think now most people, not all, but most people who arrive in detention are seen by a GP in 24 hours. But that isn't an examination that can meet the purpose of Rule 34. So it's not a targeted mental and physical examination designed at eliciting information about whether the person is at risk in detention. It tends to be a really brief assessment to meet immediate health needs, for example, prescription of medication. So that doesn't identify people at risk of harm and therefore can't lead on to a Rule 35 report. If people are identified at either the Rule 34 stage or at the screening stage by a nurse, unfortunately that now doesn't trigger a Rule 35 report immediately either. I think it used to more, and at about 2014 those two rules seem to have become disconnected, and so instead of a Rule 35 report being done straight away, people are put on a Rule 35 waiting list for a later appointment.
And we heard Dr. Uzerali talk about that on Friday. In your view, that's inappropriate, and the Rule 34 process should be leading to Rule 35 reports immediately in appropriate cases.
Absolutely. The whole purpose of the two rules taken together is to identify people immediately and root them out of detention. So if instead a waiting period is allowed, that means people may deteriorate in the meantime.
Do you have experience in relation to your casework of disclosures being made, for example, of being a victim of torture, either to the nurse or to the GP, that nevertheless didn't lead to a Rule 35 assessment or report at all?
Yes, absolutely. We've seen that frequently.
In terms of the Rule 34 assessment, or indeed Rule 35 assessments, is there an appropriate focus by GPs on mental health and vulnerabilities in those assessments?
No, as far as we can see, mental health is often not properly assessed and not properly recorded.
And what's the consequence of that?
Often that's the key evidence that really needs to go to the Home Office, and it means that that information isn't considered when detention is reviewed, and so often that means the person remains in detention when really they should not.
Where Rule 35 reports are being written, in your experience, are they of an adequate quality?
No, I think often important issues are left out that would have been really important to cover. For example, mental health symptoms. Sometimes comments are made that are really easily misinterpreted, like no severe mental health issues when there clearly are significant mental health issues. Or recently we've seen the term stable in detention very frequently, which I think just means no issues so acute as to require hospitalisation or something like that. It doesn't mean no mental health issues that are likely to deteriorate. So that really gives a wrong picture of what the situation is for the client.
And in those types of circumstances, would you be of the view that more Rule 35.1 reports, for example, should be being written?
Absolutely. I mean, the absence of Rule 35.1 and Rule 35.2 reports is a failure that just means those safeguards are non-existent in practice.
There really seems to be a focus primarily, if not exclusively, on Rule 35.3. Is that your experience?
Absolutely, but I think the purpose of Rule 35.3 is being misunderstood, in that it often gets referred to as things like allegation of torture application. And it's not an application by the person in detention. It's a duty on the doctor to report concerns. It's only because that isn't being done as it should that it then starts to be viewed as an application, and detained people are having to go and ask for one or have their solicitors inquire about it.
Yes. There seems to be an emphasis on detainees seeking Rule 35 reports rather than a view that there's an obligation on those on the other side of the equation to identify those people, make assessments and have GPs write reports. Is that right?
Exactly, absolutely.
And that's inappropriate.
That's completely inappropriate because a lot of people won't seek a report. They won't know about it. They might only find out about it once they've already been in detention for a period of time, at which point they may have suffered harm. It also leads to a perception sometimes, I think, that detained people in some way demanding when they ask for a Rule 35 report, or that they can't wait and that that's unreasonable. But of course they shouldn't be in that position in the first place.
Dr. Uzarali gave evidence about a misuse of the Rule 35 system. Do you have any comment upon that evidence?
Yes, I thought that was quite shocking, really. There seemed some reference to Rule 35 having been changed or expanded in some way. And of course that's not the case. Rule 35 has been the same since it was brought in I think 2000 or 2001, and has always been intended to pick up those, to identify those who are at risk of deteriorating in detention, by reference to these protected groups who were set out in the previous policy as protected groups. That's now been converted into indicators, because it's known that they would be particularly at risk, and that's always included torture survivors. So those people seeking Rule 35 reports, or groups arguing that they ought to have Rule 35 reports because they fall within those groups, is exactly what the purpose of Rule 35 has always been intended to be. I don't see how that could be a misuse of it.
And if the system was operating as it was meant to under the rules, it's not, we know, it's failing, but if it was operating as it was meant to, there would be no need to advocate for those people because they would already have been picked up. Is that right?
Exactly.
You also speak in your statement about a concern that there's no oversight mechanism to monitor the operation of the Rule 35 process. Is that right?
That's right, yes. There are some limited statistics that are now being generated, but they're very much focused just on the numbers. There have been a few audit or dip sampling exercises that the Home Office has done. The first one was done after a lot of pressure from us and from other NGOs through the relevant stakeholder groups, and the results of the sample were eventually lost. The second one was published, but it was completely focused on the procedural aspects of it. So that revealed that a certain number of reports were being done, some there were long delays in the response times, and a significant number were completely lost and never responded to. Later there was some diplat sampling exercises that the Home Office did, but what was never looked at was the content and why they weren't really leading to release, and what was happening to those people in whose cases it didn't lead to release, whether they were deteriorating.
So
And that really is needed.
So there's some limited audit of the numbers of Rule 35 reports, is that right?
Yes, numbers of Rule 35 reports broken down both by centre and by type, so 1, 2, 3, and then numbers of releases.
But no further follow-up as to what happened in the cases that weren't released.
Exactly, and also no analysis of the content of the reports. So, for instance, does it lead to detention being maintained if the doctor fails to comment on mental health? Those sorts of questions would be important to ask.
So it's about the quality of the report.
The quality of the reports and the quality of the subsequent detention review.
And have you raised those concerns with the Home Office?
Yes, we've raised them consistently. When I first started in 2009, I immediately started attending the DUG and DUG medical subgroup, stakeholder groups. That stands for Detention Users Group. And that was the main stakeholder group at the time for dealing with issues related to detention. That was attended by the Home Office by Phil Schoenenberger and Simon Barrett. And then later that got subsumed into the NASAF, National Asylum Stakeholder Forum, detention subgroup. And through these forums, and also in writing, we have, since 2009, raised these concerns repeatedly and have brought examples of how it fails. We've published several reports that touch on this and have brought this to the attention of the Home Office, but no effective action has been taken.
To what was their response?
Well, when we bring examples, often we get told that it's not possible to comment on things like that in such detail and that those are just individual cases and it wouldn't be appropriate to discuss them. When we bring general concerns, we're often told that these are too general and specific examples are required. At one point, there was an admission that there has been a disconnect between the doctor writing the report and the Home Office receiving them, but then no action was taken to address that disconnect. Forms were changed at one point and there was some consultation in relation to that, and we raised some concerns about the forms, but they were effectively ignored.
What were your concerns about the forms?
So in 2015, the form, previously there was one form with tick boxes for Rule 35, 1, 2 or 3, and that was changed to 3 separate templates. We were worried that there was a possibility that having these 3 forms may deter doctors from actually filling them all in.
Which seems to have been the
Which
case.
seems to have happened. We were also worried that the questions that were being asked may mislead the doctors into thinking the thresholds were higher than they actually were, which again is something that appears to have happened. I noticed that a couple of witnesses referred to the questions on the form indicating to them that there were certain steps that they should take to monitor whether deterioration was occurring. And of course that goes entirely against the purpose of the rule, which is to identify people preemptively before harm occurs.
Yes.
We also recommended, we saw some of the training slides, not all of them. We were concerned about the content of that, and we recommended audit and monitoring, and that wasn't put in place.
In relation to the definition of torture, we've heard that it changed. It was originally restricted to actions by state agents, and then it changed thereafter.
It was sorry.
Yeah.
I don't want to interrupt.
What is there any concern about the current definition of torture in relation to Rule 35?
So originally the definition was wide. It wasn't restricted to state actors. It was never specifically defined originally, but it was always understood by everyone to be very wide. And that's because a wide range of people are vulnerable to suffering harm in detention. So who the perpetrator of torture was, for instance, clinically. I'm not a clinician, but I understand from the clinical literature that is not relevant to what harm it causes. So it was always very wide. Then in about 2012, there was a few medical justice clients challenged their detention in the courts. The case was later reported as EO. And while that case was going on, the Home Office decided to limit the definition to UNCAT, United Nations Convention Against Torture definition, which is specific to torture that happens with either by the state actors or with the acquiescence of the state. And they used that to try and justify why in some of the cases of those clients who brought those cases, why there hadn't been Rule 35 reports. The Home Office at that point argued that the definition had always been uncut, but that was found not to be correct, and certainly our experience was that that was not correct. It was previously always wide. And the judgment then said that, one, it had always been wider, and two, also there was no clinical basis for narrowing it, because the impact on people who weren't covered by uncut torture but were covered by a wider definition was the same. It was detention was likely to be very harmful to them. After that judgment, the Home Office didn't implement that straight away, so we had to send another letter threatening legal action until that was implemented. And despite this judgment having already found that there was no basis for narrowing the definition, the Home Office then sought to narrow it again with the adults at risk policy. So I understand that witnesses have said that it was confusing, these changes. I think they probably were confusing, and we were really concerned at the time that, one, they didn't reflect the clinical evidence and excluded people who are very vulnerable, but also that the narrow definition is confusing and difficult to apply. What happens if the acquiescence of the state? It's a very complex question in lots of cases, and not one that GPs and detention centres are in a position to address correctly.
You have also referred to the satisfactory management in detention threshold in relation to detainees who are unwell, a test that was effectively meant to be abolished following the recommendations made by the Shaw Review. Does there remain a concern about detainees who are unwell being managed in detention?
Absolutely. So this satisfactory management provision was exactly what led to those Article 3 cases. Those were cases of mentally ill people who were allowed to deteriorate in detention because it was deemed that they could be satisfactorily managed. So that's the kind of level of harm that caused. And in the aftermath of that, Shaw published his report and recommended a return to the category-based provision. Formally, the wording satisfactorily management disappeared out of the policy. It doesn't appear in the adults at risk policy, but the way that that's constructed has essentially brought it in across the board. So level 3, which is what detainees have to get to, the evidence that they need to provide to benefit from strong protection against detention, is to show that that detention would be causing harm. And in practice, it seems to often be applied as that has already caused harm, or that will be likely to cause harm within a very short period. So that's essentially the same provision now applied across all vulnerabilities, including torture survivors.
So it's described differently, but in your view, it's exactly the same test that's being applied?
Exactly, and it has been made integral to the way that the whole safeguard works.
You heard the evidence of Dr. Uzerali and Dr. Chowdhury, I believe, on Friday. They talked about the management of ill health in Brook House, and in particular that Rule 35(1) reports were not being written if detainees could be managed in detention. Do you have any comment upon that practice that seems to be ongoing by them in Brook House?
Yes, I think that's exactly the practice that led to us seeing those breaches of Article 3 and the terrible harm that was caused to those detainees. And what I'm quite shocked about is that those doctors don't seem to appreciate that there's a lot of evidence that mental illness can't be effectively managed in detention. So there's not much that can then be done for those detained people who are deteriorating. At very best, what healthcare is able to do is accompany their deterioration.
In 2019, the Home Office suggested widening the scope of who could make Rule 35 reports, and they suggested that it didn't need to only be a GP who could write a Rule 35 report. What's your view about that suggestion?
I think it's really important that there is a role of someone who's trained to be able to do this, who has the responsibility for it. And so that other staff can report to that person. I don't see a problem in psychiatrists, for instance, being able to prepare Rule 35 reports, but I think it is really important that there is someone like the GP who's the prime responsible person for this, to make sure that it does actually happen. The other thing that was also proposed at the same time is not only that a wider range of professionals could complete the reports, but also Rule 34 was being proposed to be downgraded to simply an appointment, rather than specifically it being a mental and physical examination. And when we queried this, we were told by the Home Office that, yes, of course, it will still be an examination. But we were really worried about this because, of course, at the moment, what we are seeing is that there isn't a proper examination being taking place. And
even though one is required under the rule.
So we can only imagine what would happen if it wasn't required.
Yes. Otherwise, at least at that time, there were no other proposals for change to Rule 35, despite Shaw's recommendation that there be a complete overhaul of that rule. What's your view about what should happen to Rule 35 in the future?
It's never worked effectively. There have been lots of recommendations relating to it for a decade, and still no effective change appears to have been possible. I'm not sure that that is because Rule 35 in itself, the way it's written, is deficient in some way. I think, in theory, Rule 34 and Rule 35 could play a really important role. I think there's lots of factors that feed into why it hasn't worked so far. Part of it, I think, is that it's never been properly prioritised. I think the culture of disbelief that exists both within the Home Office and within healthcare has fed into that. And I think there hasn't been the will within the Home Office to make proper changes to these safeguards. And the only explanation we've been able to come up with for why that is because the Home Office has just not been sufficiently interested in prioritising the welfare of vulnerable people in detention. The information has been on the table for a very long time, but I think instead removals and throughput through detention and onto the plane has been consistently prioritised.
You've heard the way that Dr. Zuzarali and Dr. Chowdhury are applying Rule 35 within Brook House even currently, particularly that they're not conducting Rule 35, not completing Rule 35.2 reports, and it seems still very few Rule 35.1 reports. That's still clearly a concern.
Yes, that's still clearly a concern, and that disables those safeguards effectively because, of course, unless concerns are being reported to the Home Office, the adults at risk policy can't be applied. It's also an example of how lessons are not being learned. For example, Rule 35.2 was a feature in several inquests that were reported, but that information doesn't seem to be identified and fed back for those who work within the system.
The concerns aren't just restricted, though, to the lack of Rule 35.2 reports and Rule 35.1 reports. The system, even under Rule 35.3, doesn't appear to function adequately. What do you see as the main deficiencies in that part of the system currently?
On Rule 35.3?
Yes.
So one aspect is what we've already touched on, the connection between Rule 35.4 and Rule 35 that has disappeared. Then there's the issue that disclosures, first there's an issue with eliciting disclosure. So the expectation seems to be that a disclosure of torture would be made at the nurse screening, which can happen at any time during the day or night, in situations where the detained person is likely to be scared, bewildered, has just found themselves in a detention centre. So it's not a conducive environment for disclosures. If disclosure doesn't happen at that point, there's no follow-up. That's sort of automatic. It's then relied on that the detained person will come forward themselves. If disclosure does happen, it may lead to a Rule 35 appointment, or it may not. If it does lead to an appointment, there's then a waiting time. Later on, if the client comes forward and discloses torture, again, sometimes it leads to a Rule 35 appointment and sometimes it doesn't, and again, there are waits. And when the report is being done, a lot of clients report to us that they feel like they're rushed, they feel like the doctor doesn't believe them, isn't interested. Sometimes clients report that they had the impression that the doctor thought that they were in some way wanting to use this for their immigration case and that there weren't clinical concerns underlying it. So again, that's not conducive to trust and full disclosure. When a report is then done, often the information that's already known to healthcare, it's recorded in the healthcare records, is often not reflected in the report. I think that appears in a couple of the case studies that we've put together, where often clients will have presented repeatedly with significant symptoms to healthcare. Those are recorded, but still the Rule 35 report doesn't pick them up, doesn't analyse them in any way, or link them to what the impact of detention might be. So if someone is starting to experience symptoms of PTSD, I'm not a clinician, but it doesn't seem to be a big jump to think that that's likely to deteriorate, but that question doesn't seem to be asked. The question of the likely impact of detention is often not addressed.
So the quality of the reports remains a concern, even
Remains a
under
real concern,
Rule
yes.
35.3. Does that have a knock-on effect on the rates of release, in your view?
Absolutely. So the rates of release are low and have always been low.
And that's not a trend that's changing in any way?
It doesn't appear to. I mean, sometimes they've increased slightly, only to dip again.
Further adults at risk reform proposals were circulated, you say in your statement, by Ian Cheeseman in August 2020. Is that right?
That's correct, yes.
Those did suggest a widening of reporting under Rule 35 to the full range of vulnerabilities covered in the adults at risk policy. What's your view about that change proposed?
I think it is important that Rule 35 has widened to the full range of indicators, but the problem with the proposal was that it didn't seem to want to focus on the indicators, but the idea was that instead it would focus purely on the impact of detention. And of course that's the bit that GPs are currently not adequately reporting. So we'd be really worried that it would instead entrench this sort of wait-and-see approach that we've seen.
It was proposed that the evidence levels of 1, 2 and 3 under the adults at risk policy would be replaced by risk levels indicating low risk, medium risk and high risk of suffering harm in detention. What's your view about that?
I think that's really dangerous. I think the problem is that I'm not a clinician, but I understand from our volunteer clinicians and my colleagues that it's really difficult to predict who will suffer harm and in what time frame. And the best guide, I think, that clinicians have to make that decision is the groups that we know from research are particularly at risk of harm. So survivors of torture, those with a pre-existing mental illness, and so on. So I think going further down the route of having very specific assessments of who's going to suffer what harm within what time frame is not going to work, because it's just not possible to make accurate assessments of that. Instead, what we think is necessary is to return to the original policy of having categories where it is known that they're at risk and then routing those people out of detention from the outset and not trying to see who's going to deteriorate how quickly, because then we get into the situation of, I think Dr. Hart may have suggested that it would be better to wait and observe and monitor and then document harm that's already occurred.
It's certainly easier to do that.
I'm sure it's easier to do, but of course then preventable harm has occurred.
Yes.
And we've talked a lot about people deteriorating. I mean, I think it's helpful to remind ourselves what an awful, distressing situation that is. Dr. Bingham described what flashbacks are like. Some of the descriptions we have heard of what people have been like in detention, what they've felt, utterly, utterly terrifying, and the harm often lasts long beyond detention. So if that can be prevented, it certainly must.
Yes. A further proposal in August 2020 was that the Rule 35, 1, 2 and 3 separate forms would be replaced again by a single form focused upon assessing the likelihood of the person being harmed in detention. You've talked about how really focusing on the likelihood of harm is not what, in your view, should happen. Would a single form, though, assist?
I think a single form may assist, although Rule 35 has never worked, and there used to be a single form.
Yes.
So
it wouldn't be.
It's probably helpful to
fix.
have great forms, but I think tinkering with the mechanisms isn't going to solve the problem.
And in your view, the best proposal for change in relation to Rule 35 would be to return to a category-based approach that covered all the relevant categories that are currently in the adults at risk policy, but that would then effectively automatically trigger Rule 35 and release from detention thereafter, unless there were the most exceptional circumstances.
Exactly. I think it would need to be combined with the most exceptional circumstances threshold for release. I think it would also need to be combined with effective pre-detention screening. I think there has been the doctors have given evidence that there's a lot of pressure on Rule 35 in terms of time. And of course, part of the reason for that is that there are a lot of vulnerable people in detention.
Yes. In relation to that screening prior to detention, in your view, the gatekeeper role used as a screening tool to assess vulnerability is a weak screening tool. Is that right?
Yes, because there's no external input into it. It's purely internal. There's also no opportunity for the person who's about to be detained or their representatives to submit any information. So we've seen it to be quite ineffective.
Is there a concern about how the balancing exercise of immigration factors against vulnerability is being conducted?
That as well, and that comes back to the problem that we've seen throughout this, which is that the Home Office appears to, at every turn, prioritise removal over welfare. I mean, one of the more recent case studies that I appended to my statement is one of a man called HRB. Sorry, I need to deduce the initials from the name. Who was recognised as level 3 at the point he was detained. The gatekeeper authorised detention, it said reluctantly, and only until scheduled removal, which was shortly after. And it was clear that this man should have been released immediately when removal didn't take place. But when people enter detention, they get stuck in detention. And he remained in detention for a long period of time, deteriorated as was expectable. And that was completely foreseeable right from the beginning.
There's a DSO 04 from 2020 called Mental Vulnerability and Detention. Does that DSO in any way address your concerns?
No.
Why not?
So that DSO was proposed in the aftermath of the case of VC, which was the case of a severely mentally ill man at Brook House who was in segregation for long periods, suffered very distressing symptoms and didn't have capacity. And so he couldn't challenge his detention or the circumstances in which he was being held, force that was being used, him being in segregation. And so the court identified that it was unlawful and discriminatory, that there was no provision of independent advocacy to people in his situation. Nothing then happened until about 2019 when the first draft DSO was circulated for consultation. And as often is the case, we were given a very short period of time to respond to it. And some other relevant groups were not initially consulted, including the Royal College of Psychiatrists. And that draft DSO made no provision for that gap that had been specifically identified by the courts of the need for independent advocacy. We raised concerns about that, and there was a bit of back and forth in another consultation a year later, and eventually the DSO that you referred to was published. And again, that gap has not been filled and remains unchanged. So the DSO failed to address the main issue that was identified.
So there remains, in your view, a gap in the safeguards in relation to those detainees who may lack the mental capacity to make decisions about their detention, their medical treatment in detention, and other types of decisions.
Exactly. And we continue to see people in detention, including at Brook House, including in the last few months, who lack capacity and who are not swiftly identified and assessed, and who, even if they are assessed, there's no provision for them.
We heard from a witness from Freedom from Torture of quality standards in relation to medical reports provided to the Home Office on behalf of detainees, and that those standards set too high a hurdle because they increase the standard of proof of professional medical evidence of vulnerability, where that's from an independent person and not a practitioner working in an IRC. Is that your view also?
Absolutely. And I think those standards, the introduction of those standards, are a good example of the suspicion that exists within the Home Office of any safeguard that turns up a lot of people. This was looked at also by ICIBI, who asked for the evidence. The Home Office said that there was abuse of the safeguard that provides for MLR's medical legal reports that apply the Istanbul Protocol being automatically level 3. And we haven't seen the evidence, and neither has the ICIBI, even though they've asked for it, of that abuse. What the Home Office has done to tackle this alleged abuse is to introduce these standards. They're like a tick box. And if a report doesn't meet all of the standards, then it's given less weight. And often that means no weight in considering the detained person's detention.
They're effectively disregarded if they don't meet every single tick box.
Exactly, and some of the tick boxes don't have anything to do with the quality of the report. So, for example, one of them is that the same day the clinician, if they had concerns about the impact of detention, wrote a letter to the detention centre healthcare raising their concerns. A lot of the time it's a good thing to send a letter straight away, but it doesn't have anything to do with the quality of the report. So we have, for example, come across a client, and he's also annexed as a case study, who was very unwell. He had severe PTSD and depression. He was deteriorating. He was suicidal. And he was seen by an independent consultant psychiatrist arranged by his solicitor. Well, this was a psychiatrist who didn't have experience of working within detention, so he was just unaware of the standards. And he wrote a report which was good, as you would expect from an experienced consultant psychiatrist, raising really serious concerns about the likelihood that this person was going to deteriorate even further in detention. But because he was unaware of the standards, he didn't meet them. So he didn't send that letter to healthcare the same day. Instead, he wrote his report really promptly and forwarded it to the client's solicitor so that action could be taken promptly. But that wasn't enough, and the report was disregarded. And as a result, the client remained in detention for another month without this information being taken into account, until one of our doctors, actually Dr. Bingham, went in and saw him again and did a report in accordance with the standards. But that delay of that information being considered was completely unnecessary.
You also comment in your statement that the standards entrench the practice of asking whether mental illness can be satisfactorily managed in detention. Is that right?
So the standards require the writer to consider whether the provision of healthcare on site makes any difference, and require the writer to immediately communicate with healthcare so that healthcare can attempt to manage anything that has been found. That was one of the points that was criticised in that consultant psychiatrist report that I've just referred to, that he didn't specifically refer to what treatment was available in the detention centre. But was quite clear from his report was that the client couldn't be managed in the detention centre. So the particular detail of what treatment and what stuff were available didn't make any difference. But yes, the underlying assumption is that most things can be managed.
And that underlying assumption is wrong in your view?
Exactly. And all the evidence, as Dr. Bingham has explained, all the clinical evidence available shows that that assumption is wrong.
You also comment in your statement at paragraphs 173 to 174 on the prevalence of use of force remaining a serious concern for the IMB 2020 report on Brook House. As far as you're concerned, is the use of force still a concern in Brook House?
Yes, absolutely. And I think we see more of it when the detention centre fills up more, and possibly a bit less of it when they're slightly lower numbers. But it continues to be a concern. And I think it will always remain a concern, because if you have high numbers of vulnerable people who may present as distressed, who may self-harm, who may have disturbed behaviour, and you can't effectively manage their mental health, then you will get behaviours that in the staff there, the only responses that are available to them are the use of force and moving to E-wing or to segregation. And of course that's often accompanied by the use of force. So I think that's something that's inherent in the way that this is set up.
Yes, and use of force in relation to incidents of self-harm remains a concern.
Exactly, and the percentage of the use of force that was aimed at stopping self-harm was reported in the IMB report to have gone up. So I think it was a third of incidents of the use of force that were for that purpose. But of course we know from the 2017 case studies and from more recent cases that when force is used to stop self-harm, it often doesn't stop at that.
Yes, it was 37%, in fact, so slightly more than a third.
So even more than that.
Good memory. Dr. Uzarali, in his evidence on Friday, made a suggestion that medical justice is motivated by a political agenda, that immigration detention should be ended per se. Do you have any comment on that suggestion?
Yes, thank you for giving me the opportunity to respond to that. We do believe that immigration detention should be ended, but that is not a political view. That is based on our experience and that of our clinicians of working with people in detention and seeing the impact that detention has on their mental health. And it's based off seeing how the safeguards have consistently failed and how the Home Office has been either unwilling or unable to address that. So because of that, we see the only solution to deal with the harm that detention is causing on vulnerable people's health is to close them down. And I don't think that's unreasonable. We are not the only organisation to propose that. The other main medical organisation who's considered this is the BMA, and they have also recommended that immigration detention should be phased out. Other organisations have also thought that the safeguards aren't able to deal with the harm caused by detention adequately and that a time limit is needed. I think pretty much any body or organisation that has recently considered this issue has either recommended a fixed time limit or an end to immigration detention. I think even Dr. Uzerwali himself recommended a limit of 7 days.
So your main proposals for change, your preference would be to phase out the use of detention altogether, given the harm you've seen that it causes in vulnerable people, or if not to phase it out completely, to limit the power to detain, and in particular to put a time limit on detention. Assuming neither of those two things happens or is likely to happen in the immediate future, I think you make some recommendations or some suggestions for changes given immigration detention continuing, and some of them are set out in some detail in Emma Ginn's statement, who's the Director of Medical Justice. Is that right?
That's right, yes.
I just want to ask you about some of them on her behalf. So if you can't answer, please do just say. They are contained in Ms. Ginn's statement, which we will adduce in full. You say that detention, or she says, I should say, detention should be a last resort, and that all alternatives should be exhausted first prior to detaining someone. Is that right?
Absolutely. And I think the only reforms that have happened that have had a significant impact are those where there is both a time limit but also a process for considering the person's situations before they go into detention. So, for example, the family returns process requires a number of meetings before detention can be authorised, and for information to be obtained from, for example, the person's GP or bodies that have provided therapy or social workers, so that there is information that can be considered, which of course the gatekeeper can't at the moment.
You make some, or she, Medical Justice makes some recommendations for reform of the adults at risk policy, and the recommendation or suggestion is that there's an urgent need to return to a category-based approach, as you've talked about somewhat in your evidence, to the identification of vulnerabilities, as indeed Mr. Shaw recommended in his first report, where vulnerable people are treated as unsuitable save in very exceptional circumstances. Is that right?
Absolutely, yes.
And another suggestion is abolishing the requirement for specific evidence of risk of harm.
Yes, I think that goes with returning to a category-based approach.
So the two go in tandem.
Exactly.
You say that there should be an effective screening of vulnerabilities, disabilities, trauma and mental health problems before the person is detained, and that again goes back to the gatekeeper role. In your view, should the detention gatekeeper role be abolished?
The gatekeeper isn't independent in any way and doesn't have any access to independent information, so that's why they're ineffective. I think a more independent setup would be more likely to be effective.
And a suggestion is made that that could be a detention review panel with a procedure for proactive inquiry, so that the panel is satisfied that there are no legal or practical barriers to removal and all relevant up-to-date evidence has been obtained and considered by the Home Office about the person's health and any other vulnerability.
Exactly. Quite often when someone is in detention, a few months down the road, it turns out that there was evidence that should have been available right from the beginning that they could not be removed anyway. For example, D1914, that information could have been made available right from the outset, and he should never have been detained.
You say a pre-detention screening must be coupled with an effective clinical screening process upon a person's detention. So where that process hasn't happened prior to detention and someone been screened out, that there must be more than a tick box exercise once they've been received into detention. Is that right?
Exactly. So that's essentially Rule 34 being properly implemented.
So a proper mental and physical examination.
Exactly, focused and aimed at establishing some level of trust and eliciting disclosure of indicators that the person is at risk of harm.
And Medical Justice is of the view that Rule 35 needs complete reform. Is that right?
Absolutely.
And part of that would be that Rule 35 reports weren't routinely rejected and not leading to a release from detention. Is that right?
Exactly.
There's also an urgent need to address the disconnect between the Rule 35 safeguard and the adults at risk policy, and that's what the category-based approach would be designed to achieve, is it?
Yes, and also Rule 35 would need to cover all the categories.
Yes, which it doesn't at the moment.
Exactly.
There are various suggestions about improving training, and training's been a consistent theme. Medical Justice would like to see better training for all healthcare staff in the delivery of trauma-informed clinical care and aimed at better identification of PTSD. You'd agree with that?
I think that's really important, but I also think that training in itself is not going to solve that problem, because training is going to struggle to get at that toxic culture that exists within detention and the culture of disbelief that's proven quite enduring.
Yes. Further, better training also on the adults at risk policy and Rule 35. We heard consistent reports of a lack of adequate training in those two areas that remain the case today. Is that right?
Yes.
There should be a focus on ongoing review under Rule 35, shouldn't there? Not just a one opportunity either at the beginning of detention or when one Rule 35 assessment is carried out. Dr. Hard notes in his report that there seems to be a complete absence of any follow-up to review the ongoing detention and its impact on someone. Is that right?
Exactly. I think that's really important, but I think that review needs to be directed at identifying indicators that the person is at risk of deteriorating and not waiting for actual deterioration to occur.
Yes, indeed. In medical justice view, as both you and Dr. Bingham have discussed, that IRCs are not really a place to treat mental illness, are they? So the suggestion is that healthcare should have a responsibility to raise concerns about the suitability of the person for continued detention as soon as mental illness is identified. Is that right?
Yes, exactly.
And there needs to be better training, as we've touched upon, in mental capacity as well.
Yes, absolutely.
Part of the issues in relation to mental capacity you mentioned were the lack of a role for independent advocacy services. You would like to see the introduction of those in relation to the assessment of mental capacity.
Yes, and I think it's important that they would come in at quite a low level, so when there's a suspicion of a lack of mental capacity or concern about it.
Yes. You would like to see the ACDT process linked with the adults at risk policy and Rule 35, such that, as we've seen, does not currently happen and didn't happen in 2017, an ACDT would trigger the operation of Rules 35.1 or Rule 35.2 in the appropriate circumstance and reports made, or an alternative means for the Home Office reviewing detention.
Yes, exactly.
In relation to use of force, the suggestion is that the prison-based model of control and restraint is inappropriate for a detention centre. What would you like to see in its place?
A lot more focus on de-escalation and therapeutic interventions. I think at the moment, measures that are likely to be perceived by the detainee as punitive are the first line of response to disturbed behaviour, which is often not identified as caused by mental illness. And so you get increasingly unwell detained people behaving in ways that are difficult to manage, and then you get more and more use of force. And of course that's also distressing for everyone else there who witnesses. It just creates a sort of climate of fear, and the situations in which the IMB in 2020 said that the entire detained population was being subjected to inhumane treatment. And I think that's sort of inevitable when you get all these factors coming together in a way that Dr. Bingham described as a perfect storm. That's where the situation is actually terrifying, probably for everyone involved. It fuels decentralisation, it fuels a normalisation of the use of force and of very distressed behaviour.
And it exposes detainees to a risk of mistreatment.
Exactly. And I guess the other thing that comes into it there is the racism that's been revealed both in Panorama and in multiple other situations before in Jimmy Mubenga's case, who died while being forced onto a plane, in the undercover filming at Oakington and at Yarlswood. And as Stephen Shaw said after Oakington, being a detention custody officer is not a job just like any other. I think it does have an impact on people working in that environment to see this sort of disturbed behaviour, to see people routinely being subjected to the use of force, and of course detained people being people that their job is to manage out of the country, so the message is that they don't belong here. And I think it's quite easy to slip into that these are people who don't have the same kind of worth. So I'm not in any way an expert in organisational culture, but I think it's unsurprising that this is an issue that's come up again and again.
Yes. In relation to segregation, there are various proposals for change, that it shouldn't be used to manage or contain people who are suffering from serious mental illness or at risk of self-harming or suicide, other than in the most exceptional circumstances where there's an immediate threat to that person's life. Is that right?
Yes, absolutely.
You would like to see any transfer to segregation for clinical reasons triggering a Rule 35 report?
Yes.
And indeed, thereafter release from detention unless someone's transferred to an inpatient psychiatric setting. Because, of course, the importance isn't just the writing of the report, but what happens with it.
Yes, exactly. The reports need to be properly effective. And even Rule 35.1 reports don't always lead to release.
Yes. Healthcare staff shouldn't be approving or authorising the use of segregation, in your view.
Absolutely.
Their remit should be confined to raising contraindications or concerns and triggering a review of continued detention.
That's right.
In your view, there should be a review of the use of e-wing in Brook House, as I think your view is that it is being used informally, so not under the safeguards of the rules 40 and 42 as segregation.
Exactly.
And that can be very damaging to a detainee's, particularly mental health.
Absolutely.
In relation to monitoring and oversight, we've talked a little about gaps in oversight and monitoring by the Home Office. What would you like to see them do in order to strengthen their monitoring and oversight of the safeguards in relation to vulnerable detainees?
I think there needs to be proper monitoring and regular monitoring of not only the procedural aspects of it, but also the content and the effectiveness of it. But the other thing that needs to happen is that action actually needs to be taken. I mean, it was known that there was no Rule 35.2 reports and very few Rule 35.1 reports. And somehow that doesn't seem to have rung alarm bells either within the centre or at the Home Office. So monitoring is really important, but it's not worth very much unless effective action is taken as a result.
Yes. And in your view, if these proposals for change were accepted and were actually to occur, is that likely, in your view, to lead to less risk of mistreatment of detained persons in detention?
I would hope so, but the reason I'm really cautious is because there have been so many recommendations, and there are policies in place that on paper sound quite good if they were properly implemented, and so that's why we think that unless the power to detain is seriously curtailed, that it's inevitable that we see these sorts of abuses.
Yes, thank you. Chair, I have no further questions for this witness. Do you have any questions at all?
I don't. You've asked all of my questions, possible questions that I had, Ms. Simcott. Thank you very much.
Thank you.
Thank you.
So slightly early, lunch break. So should I suggest an hour in any event, and we'll come back at 1:45?
1:45, thank you. Thank you very much for coming to give your evidence today. I know it's not an easy experience, but it's been very important to hear from you. Thank you.